Hello, everyone. I'm Ting Liang, chairman of the first affiliated hospital, Zhijiang University School of Medicine. It's my pleasure to meet you online to share our clinical experience with counterparts in South Africa to fight against the COVID-19. First, I would like to briefly introduce our hospital. As a large-size general hospital, we have the 6 components, one of which was transferred into a COVID-19 center. Last year, recorded over 1,400 discharge and 5 million outpatient and emergency visits. In terms of the overall strength, we rank number 14 in China and number 3 specialist in national top 10. In terms of the scientific research, we rank number 3 nationally, and infection disease continue to rank number 1 in China for many years. This is why we are designated as the only province hospital for critical ill patient treatment of the COVID-19 cases. Today, I will give the presentation in 3 parts. First, we will overview our hospital fighting against this disease. Next, let's look at the overall situation at our hospital to fight against the novel coronavirus. Since the outbreak of the COVID-19, the CBC and the government have addressed epidemic as a top priority and take a swift action. Just on the Lunar New Year's Day, a leading group for the prevention and control was set up. It was made clear that people's life and health must be put first, and epidemic prevention and control are most important thing at that time. In our hospital, we took the lead in setting the 3 zeros goal during the pandemic. As we know, COVID-19 is a strong infection disease. To take care of our patients and prevent the medical staff from being infected, we announced 3 zeros. This means 0 infection, 0 missed suspect cases, and 0 patient deaths. All our medical workers, including those visiting Wuhan and Italy, was tested negative in nucleic acid tests. None of them was infected. We carry out rigorous testing and strict management so no suspect cases is missed. Thanks to the joint efforts of our staff, no patient died at our center. In Zhijiang province, 95% of critical cases were admitted in our hospital. Over 700 medical staff from the 16 specialists worked day and night to save the patient life under the leadership of the over 20 top experts. We also sent the whole team to Wuhan for medical assistance. A new campus just opened in November last year was transferred to the specialized COVID-19 disease center. The government and the hospital tried the best to guarantee necessary medical supplies for better treatment outcome. MDT meetings were convened every day to work out comprehensive treatment plans. Many life support technologies were applied. We have given the medical advice to hospital in Zhejiang as the leader of the Provincial COVID-19 expert panel. We also we have also sent about 160 medical staff to Wuhan. In addition, 7 leader experts went to Italy to give the guidance on critical cases care. During their 2 weeks stay in Italy, they went to isolate wards, exchanged the prevention and treatment ideas with Italian medical workers, and were invited to give the medical advice to oversee Chinese in Italy. This picture shows how we reconstruct Zhijiang campus. Building 3 was a moderate and severe patient treatment center, and also for the suspect patient. It contained around 250 patients. For Building 5, we have about 60 beds for critical ill patient isolate in ICU. All staff worked in isolation area were accommodated in Building 2. We also set up the fever clinical in separate areas, and the MDT meeting were held every day in Building 6. Actually, the campus was transferred within the 3 days to make it a suitable center for the patient with infected disease. Equipped with all the necessary human and medical resources, it has 100 ICU beds, 17 ECMO machines, and 106 ventilators, 30 bronchoscopies, sufficient detection and examination, etc. The second part, I will introduce the MDT collaboration during that time. With all the preparation ready, the treatment of the critical ill patients is guaranteed. Here, I post a picture downloaded from the Johns Hopkins Medicine. From the left one, we can see till August 23, the calculative confirmed cases had reached over 23 million. It is easy to see the confirmed cases increased dramatically all over the world. In China, the pandemic reached its peak in February, so we didn't have any new patients now. In total, 105 confirmed cases were admitted to our center. The mean age was 53. There has been no deaths among these patients. To be more specific, in our hospital, about the 45% was severe cases, and 34% was critical ill cases, while the rest were the moderate ones. The youngest one is 16 years old, and the oldest patient is 96 years old. Most of patients were in their 50s and 60s. 39% was aged over 60 years old. This posed a great challenge to our treatment. Now let's move to the hospital strategy for managing COVID-19. All we are share in this part is based on what happened in your hospital. The first thing we have done is to optimize the visiting process. Per-hospital management is a very, very important part for the infection control. For this part, we should avoid new hospital infection and missed diagnosis. We reconstructed our fever clinic to make the visit more convenient and safer. We also have the spread examination, lab, and observation room inside the clinic. All patients should wear masks and without company during the visit. Also, we should minimize their staying in the clinic, all the confirmed cases should be transported by negative pressure ambulance, and ambulance attendees should be well equipped by personal protective equipment. Here, all the ambulance would be disinfected after transport by local CDC agents. Here is the detailed procedure for the patient admission. Visitors with the fever should be guided to the fever clinic, and the questionnaire will be filled by patients, which includes many epidemiologic and symptomatic description. Nurse in the triage I mentioned before will classify the patient first, and provider will be responsible later. Once the number of the patients increases permanently, suspect patients are no longer tested or treated in the clinical due to the infection control. We took them to suspect the isolation wards and to consecutive negative viral detection with the interval of the over 24 hours are required. For highly suspect patients, like a typical challenge in lung image with no evidence of the other infection, they will stay in isolation wards. Once diagnosis, the patient will be transferred to the confirmed isolation wards. Next, we will share our experience in the diagnosis and treatment. Screening criteria for suspect COVID-19 cases is shown in this table. Briefly, epidemiological history and symptoms were provided by patients, and chest X-ray or CT scan and blood routine test will be done. Suspect cases will defined as patient meet one criteria, including the epidemiological history and two clinical features. Meanwhile, patients without epidemiological history but have three clinical features are also included. Once patients do not meet the criteria, it is hard to exclude them from the suspect cases. Physician could report it to experts consultation team for the discussion and give a final decision. All the suspect patients will be admitted to isolation wards, and once nucleic acid detection of the coronavirus in upper respiratory specimen is positive, this patient will be confirmed and transferred to another isolation ward. In consideration of the false detection, I mean the false negative, suspect cases with the typical manifestation in the CT scan of the chest, like patchy ground glass opacities and multifocal consolidations, can be treated as confirmed cases even if the RNA detection is negative. This method is very important to prevent the false negative patient. All the mild, moderate, and severe cases will be admitted in regular isolation wards, while critical will be admitted in the isolation unit if necessary. To our knowledge, about around 80% confirmed patient had a clear exposure history, and clustering occurrence were common. We found the 11 cases in one plan from the Malaysia, 16 cases in one from the conference hosted by commanding patient. Over 30 cases in one temple gathering. Fever is the most common symptoms, followed by the respiratory symptoms, mainly dry cough without expectoration, and it may be deteriorated to chest distress and shortness for breath. Some patients may complain of the general symptoms like the fatigue and muscular pain. A symptomatic patient are another big challenge for the infection control. Patients are likely to have the normal or decreased white blood cell with the lymphopenia, mild elevated CRP with normal PCT, and partially with the liver and cardiac function injury. Here we conclude typical feature of the chest imaging in COVID-19 patients. While they are not unique, in moderate cases, unilateral or bilateral peripheral ground glass of cities with the hazy rim could be found normally without nodules. Pleural effusion, no lymphadenopathy. In severe cases, we can see the bilateral peripheral ground glass of cities, paving with the consolidation. In critical ill cases, consolidation linear obesities, architectural distortion, bronchial dilatation, white lung, and pleural effusion could occur. Next, I will introduce our treatment protocol. To our knowledge, for patients with receiving the ritonavir-boosted lipinavir combined with the Abdul in our hospital, the average time to achieve the negative viral RNA test for the first time was 12 days. Other alternative candidate could be interferon nebulizations, copy-cysted boosted donavars, and fabulary. This kind of antivirus drugs, up to now, we have no evidence to is effective. But at that time, we usually give the patient antivirus drugs. The treatment course or regimen had not been determined and are usually around 2 weeks. Antivirus drugs should be stopped if the RNA test result is negative. Our understanding about the therapy is still limited. Just as I mentioned, further research focused on the effect about the medical medication are still urgent and necessary. Appropriate and short-term uses of the steroid to inhibit the cytokine and chemical release to prevent the disease progression may be necessary and should be considered for the patient with a severe COVID-19. In our clinical experience, steroid usage is necessary for the critical ill patient treatment, and it can prevent the moderate transfer to the critical ill patient if you use the steroid use as soon as possible. I mean, as early as possible. However, a high dose steroid should be avoided due to the adverse events, and I mean the side effects and the complication. It's just we know in the compared with another infection disease before. The patient will, if you receive a large dose of steroid, maybe the bone necrosis afterwards. Patient made one of the following condition are suggested to have the steroid treatment, such as severe or critical ill patients, persistent high fever. CT scan shows the very, very typical lesion, or more than 30% area of the lung involved or be infected. I mean, chest CT scan showed a rapid progression, and the IL-6 level is more than 5/4 of the limit of the normal. Initial dose of the methylprednisolone is we also use about 1 milligram per day per kilogram intravenous, and 15 to 18 milligram twice a day can be considered for the progress patient and critical ill patients. Depends on the patient situation. For patients with hypoxemia, oxygen supply is very important and critical. Continuous oxygen saturation monitor during the oxygen therapy is required. The time for the oxygen therapy is when oxygenation index is below 300. The treatment goal is to maintain the oxygen saturation at the 93 to 96% for the patient without chronic permanent lung disease, and at the 80% to the 92% for the patient with chronic type 2 respiratory failure. Especially, the oxygen concentration should be increased to the 92 to 95 for the patient whose oxygen saturation drops below 85% frequently during the daily activity. For patients with the following condition: oxygen saturation below 93, PF ratio below 300, respiratory ratio over 25 times per minute at bed, or remarkable progression on X-ray or CT scan, high volume nasal cannulation should be considered. An initial flow of at least 60 liters a minute should be given immediately for the patient with obvious respiratory distress. Tracheal intubation for patient is dependent on the disease progression, systemic status, and complication of the patients. For those with stable situation but with a low oxygenation index, prone position ventilation is also necessary and important method and technology. Is recommended as a routine strategy for patients with oxygen index less than 150 mercury, or without obvious imaging manifestation without contraindication. Times course recommended for prone ventilation is more than 16 hours each time. It can be ceased once the oxygenation index is greater than 150 millimercury for the more than 4 hours in the supine position. For mechanical ventilation, non-invasive ventilation and invasive mechanical ventilation could be chosen. A short time, usually less than 2 hours, use of the NIV can be closely monitored if the patient have the acute left heart failure, chronic obstructive pulmonary disease, or immunocompromised. Intubation should be performed as early as possible. If the improvement of the respiratory distress symptom or oxygen index is not observed, NIV with double circulars is recommended. NIV is not stronger strongly recommended in COVID-19 patients who failed HFNC treatment. Tracheal intubation should be performed as early as possible for patients with oxygen index less than 150, with symptoms of respiratory distress or multiple organ dysfunction within 1 to 2 hours after even give the high flow and high concentration treatment, oxygen treatment. Strictly set tidal volume to the 4 to 8 milliliter per gram. In general, the lower lung complaints, smaller the per set tidal volume should be. I just mentioned is the intubation indication for the patient. ECMO treatment should be considered for some patient based on the following timing. For the salvage ECMO, patient should be stayed in the state of the mechanical ventilation support. Measures such as lung protective ventilation strategy and prone position ventilation have been taken for the 3 days and no effective, while the situation still deterioration and the patient becomes worse and worse. At this time, ECMO should be used. For the replacement of ECMO, when the patient is not suitable for the long-time mechanical ventilation support, for example, the patient is not suitable to obtain the expect of the result, ECMO will be given sooner or earlier, just as I mentioned the criteria. I mean the patient if we give the hypothesis and prophylaxis, we suspect the patient even give the intubation, tracheal intubation, the no effect, best effect will be attained. ECMO will be given quickly. For early awake ECMO, I mean the patient is awake but receive the ECMO treatment. It can be applied to the patient who have been supported by the mechanical ventilation with the expect high parameter for more than 3 days and who made the necessary of the condition of the awake ECMO. Awake ECMO has some many best effect. For example, it can be the patient, can be the nurse, very clearly and suitable and safer. The first choice of patient of the respiratory impairment is the VV model. This is the type of the ECMO model. I just introduced the ECMO subtypes, including VV model. Well, for the respiratory fail patient complicated with heart disease, heart function fail, I mean, VAV model should be considered is the best choice. For the COVID-19 patient with not severe respiratory fail, but complicated with serious heart outcome, leading to the cardiogenic shock, the VA assisted by ECMO model should be selected. So the 3 types of ECMO will be selected. One is the VV, one is the VAV, and another is the VA. Depends on the heart lung disease function. When considering wearing from the ECMO and the mechanical ventilation, first try to remove the artificial airway unless the patient had ECMO-related complication, or the expected time of remove all the assisting machines is less than the 48 hours. For patients who has too much airway secretions, that frequently artificial suction clearance is needed, who is expected to have the long-time mechanical ventilation support, who satisfy satisfied with the condition that the oxygen index over 150 millimercury and time longer than the 48 hours, whose lung imaging change for the better and whose damage related to mechanical ventilation pressure have been controlled, the ECMO assistant may be removed. This is the criteria of the what time the ECMO will be stopped. Application of the bronchoscopy is also another very important method for the modalities for critical ill patients. Collection of the respiratory specimen for the lower part of the tract for SARS-CoV-2 or another pathogen guide the selection of the appropriate antimicrobe drugs, localization of the bleeding site, stopping of the hemostasis, spreading of the blood clots, remove local rejection of the cold saline, and get some drugs delivery, and some aim of the diagnosis, and instruction of the succession of the spreading. Assistance in the establishment of the artificial IV. This is very important of the treatment part. Guided tracheal intubation or percutaneous of the tracheotomy. Drugs such as the infusion of the alpha interferon and some another drugs admitted. Other therapies was also used in some patients in our center, like the artificial liver support system, which gave the cytokine suppression and the control the level of cytokines in the bloodstream. Routine uses antibiotics to prevent the secondary infection, balance of the small bowel function, and nutrition support. This is very also important. ECMO support, convalescent plasma therapy, and traditional medicine, Chinese medicine usage. In our hospital is a critical care center. Many patients have serious underlying disease, including the uremia, liver transplant recipient, and the cancer patient, etc. During the treatment, patient completed with another symptoms, hemorrhage, bleeding from the upper GI bleeding and low GI bleeding, or other main organ dysfunction or function fail were common. Many suffer from the poor pulmonary condition, like the consolidation of the both lungs. Severe bacteria and function infection is usually in the patient body. This table shows the life support persists in COVID-19 patients of the hospital, like the 2 cases with the double lung transplantation, 11 cases with the ECMO support therapy, 16 patients with the tracheal intubation, and 11 cases tracheotomy. We have done the 106 person time the bronchoscopy, 35 gastrointestinal endoscopy, 71 artificial liver support system, and 341 CRT already. We also did coronary artery stent inflammation, the PCI, radical surgery for the sigmoid cancer, C-section, temporary cardiac pacemaker implantation, hemostasis with the embolization, the Seldinger method usage for the hemostasis, vessel ligation, and closed thoracic drainage in some patient. Besides, 21 patients received convalescent plasma therapy, and the total volume reached 21,000 milliliter. Patients made the following criteria could be discharged. One is a febrile for the over 2 days, release respiratory symptoms, negative RNA detection of the specimen twice, continuously with the interval over the 2 days. A permanent improvement lesion in the chest CT scan, oxygen saturation is over 93 without oxygen supplication. 2 weeks or home stay isolation well with a qualified requirement is needed. We also follow up the patient every week. So after 2 weeks, the patient will go to hospital for the follow-up and give the CT scan again. Next, I will share some of the special cases of COVID-19 with you. The first one, very interesting, is the 19-year-old male patient with chief complaint of the fever, cough, and shortness of the breath for the 3 days. Typical change could be found in his chest CT scan. Even though the chest lesion was not very severe, the situation was worsening, and heart failure occurred in this patient. We did the mechanical ventilation on February 13th and tracheotomy 10 days later. He faced the case-related secondary infection, and he had recovered well, smoothly, from the units. The second case was the first COVID-19 patient receiving the lung transplantation. Here, we can see the lung turned completely white before the surgery, and no sign of the recovery was found. After comprehensive evaluation for this patient, we give this patient a mechanical, the tracheal intubation and ECMO for many days, even though the lung function cannot recover. So we decided to get the lung transplantation. We performed the double lung transplantation on March 1st and March 6th, ECMO were removed. Graft function worked well in this patient and recovered and discharged smoothly afterwards. It is also the first lung transplantation for the older patient with COVID-19 in the world. We published this paper in the annual surgery before, in the general annual surgery. And later we performed another double lung transplant in March. Both patients have weaned from the ECMO and removed well now. The third case is a male, 62 years old, and had fever and cough for 2 weeks on admission. His condition didn't improve after treatment at the local hospital and was transferred to a hospital on January 29th for the repeated GI bleeding. He was on the ECMO. Despite his critical illness in lung, he was diagnosed of the sigmoid cancer during the colonoscopy examination on the GI bleeding. For the GI bleeding, MD support was offered to save his life, including the endoscopic hemostasis by the embolism, the adjustment formed by the cell Dinger's method, and the radical section of sigmoid was done, and the patient recovered smoothly. The fourth case was a young patient, a female. She was hospital with a chief complaint for the 3 days, and 35 weeks plus the 2 days of the gestation. He had a fatal distress. Fortunately, Cessation was completely successful. Swab was obtained immediately at the time of the baby was taken out of from the body, from his mother body, and amniotic fluid, umbilical cord blood, and placenta specimen was tested for the virus RNA detective. All the specimen RNA detective were negative. This shows the baby not be infected for his mother. I mean the virus not transfer for his mother to the baby. The baby will transfer to children's hospital by the negative pressure ambulance immediately, and the patient and his baby is well. We just following on in recent days. This shows the discharge since of some patient, such as the 19 years old the grandmother. The first confirmed the case in Zhejiang province, and a woman pregnant for the 27 weeks. All of the 105 patients in our center recovered and discharged. The cure rate is 100 and mortality is 0. To learn more about the novel virus, scientific research is underway up to now. About the 30 emergency project were approved with over the 20 million yuan grants. Besides, nearly 80 SCI paper published in our group for share of the combat against the COVID-19 disease with the colleagues and physicians in the world. The most prestigious journal in the field of surgery I just mentioned is the Annual Surgery. And we also published 2 papers in BMJ, GOD, and JAMA, etc. To reduce the pressure of the hospital fever, clinical, and chance of the cross-infection, online fever clinical we are opened with a 24-hour service. As of now, up to now, the clinical case served over 2,200 patients and answered nearly 1,000 questions with 66 doctors and nurses on call in Zhejiang. And many people have gone abroad for the business or study and students, etc. To better take the care of the overseas Chinese, the online consultation platform for the overseas Chinese was established. Near 100 people from the 12 countries visited the platform to seek the medical advice regarding the treatment and prevention of this disease. With the situation in China getting better and better, we actively take part in international exchange and cooperation. As up to now, we have held 25 video conference and telemedicine meeting with 260 institutions from the 50 countries. Participation including 7,000 people from the US, Suriname, France, Germany, Russia, Estonia, Japan, Australia, etc. in the world. To name some, we have held a video conference with Yale University from the USA, Health Bureau from the Russia, Chinese General Hospital from the Philippines, Ministry of Health from the Argentine, World Bank. During this year G20 summit, President Xi Jinping gave the keynote speech on the COVID-19 and called for the all-out global war against the virus. As she spoke, our hospital appeared on the station as an instructive example. On March 18, an English and Chinese version of Handbook of the COVID-19 prevention and treatment was launched by our hospital. The Handbook received a wide response in the world. As of June 12, it has been translated into 22 other languages and downloaded about the 620,000 times by use from the 262 countries and regions. The handbook was also shared in the homepage of the Nature Journal. We have received numerous of the emails from all over the world, discuss the treatment plans, and share their recognition of the book. The handbook is of great help for the medical counterpart taught by the virus, and most hospitals in Turkey are following the protocol. In cooperation with Alibaba, we also set up the global MediXchange to combat COVID-19 for the real-time communication with the doctors across the globe. Since it's launched on March 18, 17 live courses have been given on the Dean Talk, with 321 participation from about the 80 countries. Nearly 1,000 questions have been solved and discussed and answered. Thank you so much today, and I hope our experience can give you a little help in your work in future. We'll have more cooperation opportunity with South Africa, just as the President Xi Jinping said, with the confidence and the solidarity. A sensory-based approach and targeted measures, we will win the battle to contain the virus. We firmly believe in it and hope that South Africa can defeat the virus, together embracing the promising future. I'm sure in your country you have the many experience in the control of this disease. I just mentioned and introduced our hospital, the primary experience. So I believe we will exchange in later and share our bilateral experience. And I hope South Africa will recover quickly against this disease. Thank you very much. Thank you for your attention.